Thank you for having me, and thank you for the kind introduction. As Max said, Loren Adler. I'm the fellow and associate director at the Center on Health Policy at the Brookings Institution in Washington, D.C. We are a nonpartisan think tank and research organization that does research across a host of topics. Obviously, my focus is in the healthcare sphere of that. With that, I wanted to get started to, I'm here today to talk specifically about private equity. Obviously, there's going to be a lot of overlap with Aaron's amazing presentation from beforehand, just because a lot of private equity is sort of a means to drive consolidation. So you'll see some overlap, and I noticed one graph she had in her presentation that you're going to re-see. But to start with, just to kind of fix ideas a little bit, when we're talking about private equity here, obviously this is just one form of consolidation, and we're going to try to differentiate a little bit from other forms of capital, like venture capital or sort of private investors who might just give a little bit of money into something. Whereas with private equity, we're really talking about an institutional private equity firm who pools money from investors and then uses debt, basically borrows money to sort of purchase a, in this case, typically a physician practice or a hospital or a nursing home. And the sort of typical model here is that private equity is effectively sort of guaranteeing or trying to get 20% returns for its pool of investors, and and generally exit their investment somewhere between 3 to 7 years. So it is they're generally focused on a relatively short time horizon where they are trying to generate a lot of profits. Sometimes you'll hear people talk about that might sort of make them very focused on the short term at the expense of the long term. And they might just sort of strip assets and things like that. I like to sort of to caveat that a little bit and say, right, fundamentally, they do care about the long-term profitability of the company because they're trying to sell it 5 years from now for more money than they bought it for. And right, they're only going to be able to sell it for more if the next investor thinks it's worth more money. So right, in some sense, they are worried about the long-term profitability of the company. However, they are generally going to be less risk averse than maybe a typical investor because they are trying to get very high returns. They may be willing to take bigger risks. And when we're in the healthcare context, I think that's where you get some concerns, particularly in industries where there are very high fixed costs, like running a hospital system or running a nursing home, where there are sort of buildings here and real assets where you are at risk of, if you declare bankruptcy, that the institution may even go out of business, or at least go through some troubled times. Physician practices, that may not be as much of an issue because if a physician practice, technically goes bankrupt, all of those people still have an MD and can sort of work in a new practice quickly. So that just sort of give a little bit of what we're kind of focused on here. And then just to kind of for an agenda here, going to kind of just talk through the descriptive trends, like how much, where is private equity focused, how much of the market are they kind of taking on, then walk through some of the evidence on, what do we know about the effect that private equity is having on healthcare markets to date. Again, some of that's going to overlap a little bit with what Aaron spoke about. And then actually a lot of overlap with what Aaron spoke about. I'll sort of end on a little bit of a discussion about policy options. And again, really welcome a robust Q&A, and happy to kind of talk through anything afterward, including after the fact if folks want to email me and reach out. So I'm going to kind of take this in turn. First looking at hospitals, right? There have been this doesn't get most of the attention with private equity, although in recent vintage with the Steward bankruptcy focused in Massachusetts, it's gotten a little bit of renewed attention. But there have been 42 private equity deals focused on 282 hospitals over from 2003 through 2017. That's out of about 6,000 hospitals, so it's not a huge number of hospitals, but it is right. This is still meaningful, and there's been some very large ones including HCA at one point went through private equity ownership, not anymore. And then there's the nursing homes. So these are the sort of the areas of healthcare where there are usually assets like a building, real estate involved. Nursing homes, GAO, and then another paper from Tyler Braun at Cornell and colleagues both estimate that about 5% of nursing homes now have private equity ownership, or as of 2022, I should say. And then we also see from Richard Scheffler and colleagues at Berkeley, we've seen a lot of PE buyouts in hospices, really as a very recent phenomenon, as there have been slight bump ups to some public payer rates into the industry. So we are seeing a fair amount of activity in these spaces. I think what's gotten a lot of the attention, and to be a little bit what I've focused a lot of my research on in recent years, is the rise of private equity in physician specialties. And this one, you can see a real market increase. So these are sort of focused on the office-based specialties for the most part. And you'll see there was sort of first this bump up in dermatology, which was kind of the first area where private equity started getting involved in these office-based specialties. And then really starting 2019 or so pretty recently, there's been just a very rapid increase, across sort of GI, urology, OBGYN, ophthalmology. So there's been a very large, push in these areas to the extent that about 14% of the national gastroenterology market is operated by private equity firms at this point. And obviously smaller numbers for other ones, but again, this is only through 2021. You can see the angle of these lines. This has been pretty rapid growth. I think there's been a little leveling off in some specialties just as interest rates have gone up, but you're still seeing a lot of rise, and now kind of baking into a little bit of, some of these are kind of some bread and butter office-based specialties. GI has the advantage that you also are often, you can own the ASC as well. So you can own the facility where, where the colonoscopy or something like that is happening. Dermatology, kind of, you might have a side cosmetic business on the side, right? There's some aspects of each of these. And then more recently in like oncology, oral surgery, you've seen anything where there's sort of an expensive common procedure to handle. You've seen in some healthy entry by private equity. And those, I think, in some degree sort of focused on the rise of sort of both Medicare and commercial insurers kind of focused on some more value-based payment arrangements for kind of expensive procedures. Then also just to show, this is from my own research with colleagues, where focused on, right, even earlier than what I was just showing you, there's been very large penetration into emergency medicine and anesthesiology. Right, this was sort of the ones that kind of got all of the attention during the surprise billing debate back in the late teens, where we've kind of grown really rapidly since 2009, where there was not much PE investment in emergency medicine and anesthesiology to these are actually low. Conservative estimates have since updated. It's really about 30% of each of these markets are now operated by private equity firms. Those are starting to level off a little bit. It doesn't seem there's been as much growth in the last couple of years. And there's been a little bit of that shift over to office-based specialty. And just to sort of hone in, given the audience here, I wanted to bring up some Nevada specific numbers here. Nevada, just based on these numbers on the last slide, it's about, statewide, about 43% of the, since those were a little low, about half of the emergency medicine and anesthesiology markets in the state are operated by either private equity firms, or in the anesthesiology case, actually a big player was, I should say, back then, was American Anesthesiology, run by Mednax, which used to be a publicly traded company and has since sold itself to a private equity firm now. And you can see right in Las Vegas, in the hospital referral region where Las Vegas sits, right, these are even larger in emergency medicine. And then in Reno, right, it's about 60% of the anesthesiology market is PE, and actually not as heavy in the emergency medicine space. I kind of want to turn a little bit here because the sort of focus of this talk is private equity, but I do like to come back to the question of broader consolidation as well, because, right, a lot of what the private equity firms are doing is driving consolidation, particularly in specialties that hadn't been fully consolidated by hospitals. So specialties like dermatology and gastroenterology, particularly dermatology and ophthalmology, actually never had that much hospital ownership. So private equity, it was a relatively fragmented market. Private equity was able to go in and just sort of use the standard playbook of, right, you combine 10 small dermatology practices into one big one. All of a sudden, you have more clout, more bargaining power with insurance companies to get more money and get higher prices. That's like a standard kind of, your Econ 101 version of the sort of healthcare marketplace. And that is in part what we're seeing. And right, this is from a health affairs paper recently that came out, which very nicely documented that in about 1/3 of MSAs, so kind of like an urban area plus surrounding areas, in 2021, PE firms collectively held at least a 30% market share in at least one specialty, and in about half of those, PE firms collectively held more than half of the market in at least one specialty. So, right, so it is pretty widespread across the U.S. If you looked at a map, it tends to be in bigger cities. There's a lot of this in the Southeast, some in the Northeast, and a fair amount out west, particularly kind of across California, some in Nevada, and in Arizona, actually. Colorado, actually, in particular, I should say. Again, right, this was the graph that I noticed in Aaron's presentation as well. The data is old here, but it is nice because it combines all of the different kind of, the consolidation across different industries and healthcare, just to show, right, again, we have a big trend in recent vintage is that we have very consolidated provider markets that have only grown more so, particularly that primary care physician one and the specialist physician, right? Those are the ones that you've likely seen significant growth in since 2016 when this graph cuts off. But right, hospital markets are kind of the big one where, this is 90% of the hospital markets in the country would qualify as highly concentrated by our sort of antitrust regulator standards. A lot of those are smaller ones. So it's about 2/3 of the US population. If you want to put it in this sort of like a population terms, about 2/3 of the US population lives in a highly concentrated hospital market as of 2016. And that's probably grown somewhat since then. Turning the page a little bit, and next it's helpful to talk about what we know about the impact that private equity is having. I think the effects largely mirror some of what Aaron said, but I'll go through. There's been some evidence on, and sort of that this may differ somewhat by specialty. And I think it's important to kind of think through why that might be. So first off, starting again with hospitals here, a great paper by Sneha Cannon and colleagues, finds that when private equity acquires a hospital, there is actually a pretty substantial increase in hospital-acquired adverse events like falls, misplaced lines, that sort of thing, where there is actually pretty sizable effects here in sort of adverse events that folks might be worried about. We also see a fair amount of evidence that the charges or the sort of list price per inpatient day that hospitals are charging does grow pretty substantially upon acquisition by a private equity firm. In that paper, we do also see that there was some improvement on at least some quality measures and flat on some other ones. I think this gets to a point that I'll touch on a little bit later that, private equity firms may be just sort of the corporatization of the sort of operations may help you meet certain things that are kind of checklists in some way, right? You need to hit a quality metric that matters for payment somewhat. I think you can spin a story there where private equity or sort of just a bigger corporate investor in general may be better at, going towards the test. And then lastly, one paper tried to look at the effect on negotiations between hospitals and commercial insurance companies, and basically found that the sophistication of private equity in the negotiations led them to be able to get 11% higher prices when private equity acquired a hospital. Um, Nursing homes, again, Aaron did touch on this, and this is where we actually have the sort of strongest evidence, I would say, of adverse impacts where we have evidence that basically there was when private equity takes over a nursing home, there is a precipitous drop in the sort of frontline staff that's used. So the LPNs, the CNAs who are kind of doing the day-to-day care of folks in the nursing homes, and seemingly as a result, that there is, an 11% increase in mortality on average when private equity is acquiring a nursing home. Right, obviously, that is a pretty large effect and something to be that I think is very reasonable to be worried about here. There are other papers similarly finding some negative effects in the nursing home context, where finding associations with higher Medicare costs, higher sort of ED hospitalizations where there's an issue at the nursing home that ends up leading to a hospitalization. Then turning over to the sort of medical groups or the physician specialty markets. Again, this one we actually have a pretty wide range of evidence across various specialties here that private equity tends to lead to increased prices, at least on the price channel. And then we have pretty strong evidence that private equity is typically going to increase prices. In the anesthesia context, there's estimates that it increases prices by 26%. Yashaswini Singh and colleagues looked across several office-based specialties and found price growth that was 11% faster in the PE acquired practices compared to kind of similar non-PE acquired practices. And then Scheffler and colleagues similarly looked at kind of across 10 different specialties, actually. One, they similarly found sort of price increases in most of those specialties when PE was making acquisitions. But again, to this sort of broader consolidation point, I think they also helpfully looked at what happens when PE is making an acquisition in a market where they already have a dominant market position. In this case, defined as they already control 30% of the local market. So maybe 30% of the local GI market or the 13%, 30% of the local dermatology market. So what are the price effects in those cases? And here they are showing that basically these acquisitions have larger price impacts where the market is already heavily concentrated, which is sort of stems from kind of the natural logic here. But basically, I think raises a reason to be more concerned even when these are sort of serial acquisitions, when there already is a dominant position for this private equity acquirer. On the sort of quality or utilization side of things, we have less evidence, I would say. I think in the emergency medicine and across in dermatology specialties, we do have some evidence that the private equity practices or private equity ownership tends to make greater use of advanced practice providers. So they are typically going to try to substitute somewhat for sort of non-MD staff or substitute for MDs with non-MD staffs, using nurse practitioners or physician assistants to sort of help with some of the caseload. I think there's also just plenty of internal, if you read the documents that they pitch to their investors, they're pretty clear, at least in the emergency medicine context where I've done a lot of work. They are very clear this is part of the sort of cost side of the strategy that, you pay a physician assistant a lot less than an emergency physician. They are trying to use those providers to take care of less complicated cases. So it is not clear on net whether that is a good or bad thing. We talk often in healthcare that there are plenty of things that a nurse practitioner can do that probably you don't need a doctor to do. So there may be some actual cost advantages on that side. On the flip side, there are some who would argue that, sometimes due to understaffing or what it might be, that the NP or PA is sort of forced to do to deliver care that is sort of beyond their pay grade. And that can, there's certainly arguments that would lead to adverse consequences, both in the emergency medicine context or just sort of overutilization of care is sort of the common thing you'll hear, where in the dermatology context, maybe they would just, cut off more moles and send them for testing because they're less sure, just from kind of the standard taking a look at the mole, whether it might be cancerous or not. The very recent evidence, where the sort of most positive evidence of sort of corporatization that we've seen so far is from Umbar, Laforgia, and Bodner here recently, focused on fertility clinics and fertility chains in particular. These are largely with private equity investment, but the paper is kind of focused slightly broader than that. Nonetheless, right, they find that basically when a fertility chain acquires a fertility clinic, that you see a lot more utilization. So a 27% increase in the number of IV cycles delivered and a 13.6% increase in IVS success rates. So that's something they are doing. They sort of talk about it as diffusion of expertise and best practices that they are, because they show basically, right, there's a reduction in multiple embryo implantation and a higher rate of single child birth, which is sort of the gold standard in IVF, and find pretty positive effects here. I'll come back to the sort of, I'll try to summarize things a little bit later. And then, I think just one more point here. Again, given that so much of what is happening here is private equity consolidating a bunch of local markets, again, right, I often think it's important to just think back to our kind of standard horizontal consolidation generally is a net negative, at least beyond once the market is, if the market is 200 providers in the same specialty, it's not really going to matter whether two merge. But when there are, only 3 dermatology practices in a city, when 2 of them merge, right, that's sort of the case where you might think there could be, I think expectations would be of net negative impacts on consumers. Right, there actually is not a ton of evidence in the physician space. There's a ton in the hospital context, but nonetheless, the evidence that we do have is pretty unambiguous that horizontal mergers between physician practices tends to lead to an increase in prices, and typically without any sort of commensurate increase in quality here. And again, right, this is the physician consolidation specific evidence, and we've sort of put to the side all of the other consolidators. But a lot of the evidence we have Aaron talked a lot about vertical consolidation, for instance, between hospitals and physician practices. But again, much of what's going on there is the hospital is acquiring, 5 orthopedist practices in town. And fundamentally, a big part of what they're doing is actually, right, we call it vertical consolidation, but a lot of what they're doing is horizontally consolidating specialty markets, right? It's something like half of doctors in this country now are employed or affiliated with a hospital system, right? That is inevitably that the hospital just owns a very large market share of various specialty markets, and that is what's giving them a lot of leverage. And a lot of the sort of negative effects you see of that context are really just a horizontal consolidation story here. Before turning to the what to do about it, I do think it's worth stepping back and thinking about the evidence that we've seen here. And just because I think it's useful, given that there has been some evidence of positive effects, and there's, if you look at the evidence surrounding private equity in other sectors of the economy, they often are driving some form of efficiency, and they are often sort of making the business itself more profitable on average. So what is sort of so different about healthcare contexts, and is there any heterogeneity within that, right? The sort of context where we have some evidence of positive effects is fertility clinics, where one, it's a very consumer-facing industry. There is usually a lot of planning going on. Consumers are usually shopping around. There are pretty well-known metrics to sort of judge fertility clinics against each other. So there is just a lot more room for sort of consumer input into that market, where I think there's a stronger argument that private equity might be useful in that context. You could spin a similar story in primary care, where again, patients are generally can be pretty mobile between primary care physicians, particularly in the commercial market, where you can switch your primary care doctor. A lot of what patients care about is actually sort of how easy the system is to book appointments, how quick you can get an appointment, things like that, that aren't actually, about how sort of good the healthcare is there, but the sort of patient experience. So I think it's certainly plausible you could see sort of improvements to patient experience coming from this. Where you see the sort of very strong negative consequences, I think of as the specialties, was kind of the least consumer input, and where it would be very, like, I don't want to say that transparency would sort of solve all this, because I think there's sort of only so much, like, transparency can't really do much to make consumers shop for emergency care or an ambulance, right? There's some limit to how much that can ever really happen, or an anesthesiologist, right? In those areas, we've seen plenty of, it seems private equity was pretty good about taking advantage of sort of various market failures and sort of perverse incentives throughout the economy. So in the surprise billing context, we saw some of the private equity owned staffing companies be particularly aggressive in that context. But again, there's sort of very little consumers can do to police that on their own. I think even in the office-based specialties, there may be some element, and I do think there's, the verdict is still out on the sort of quality end of the spectrum, right? The evidence on the price impacts, I think, is generally pretty clear here. But it is, maybe it's plausible in the GI context there could be quality improvements. I don't think we know for sure. But nonetheless, I think, one, that is a very important area for robust study. But again, there's still only so much, like, patients in general are doing what their primary care doctor, what some doctor told them, which doctor they were told to go see. There's typically not a lot of shopping around for, across various providers. And I think some limits to how much that even plausibly could happen. So I think it's important to think that there may be some heterogeneity here in terms of when you think about the solutions here. So again, right, I think there's sort of two buckets of solutions. I'll start with these are the solutions that would sort of be a good thing to do regardless of whether private equity is doing the consolidating, or hospitals or insurers or whoever else is just sort of, big independent company is doing the consolidating. Right. But these are still tools that would limit the attraction to private equity, because this is part of what they can take advantage of, right? So one, if it was just simply difficult to merge together to acquire 20 practices in the same area, right? The sort of standard private equity model is you buy one big practice, the sort of platform practice as they would call it, and then you buy a bunch of smaller, what do they call an add-on practice, which might only be like a two or three dermatologist practice. You buy 20 of those up, now you have a giant behemoth in your local MSA, and can really wield a lot of power. And some of that's almost arbitrage. It is, this small practice wasn't able to get that high of a payment rate out of the insurance company, but us huge company can. So if we just acquire them, and now we basically bargain on their behalf, all of a sudden that company is that smaller practice is, those doctors are getting paid more money per service. So, right, I think there is just a very vital role for state and federal antitrust enforcement. I won't belabor too much, since Aaron kind of went through a lot of the detail here, but I think there's a lot of value in the transparency side here, right? You can't stop what you don't understand. And right now we really have limited visibility into, right, all these sort of evidence that I've collected here is a little bit hodgepodge, always slightly incomplete, because there's no one place to sort of figure out which PE firms own which practices. So I would take all of these estimates as sort of conservative, because inevitably sort of researchers are not capturing every acquisition that happens. Trying our best, but there's just no perfect way. So one, just actually having some transparency, and the state level can require this. There isn't a lot on the state side towards this, but there's been a fair amount of proposals more recently trying to require notification even when it is a small acquisition, right? If you are a larger firm that has acquired before, or you have more than a certain share in the market, then you have to notify antitrust authorities. Again, a similar thing could happen at the FTC at the federal level. I do think, and Aaron kind of mentioned this a little bit as well, that part of the issue here is simply, can antitrust regulators win in court? Right? You can try to enforce all you want in antitrust, but if you're not winning the cases, it's not going to have that much of a chilling effect, right? The sort of big goal here is, right, you try a few cases, a few big ones usually, and the emerging hospitals or the emerging PE firms, they lose, and then the next group of them doesn't even want to bother because there's a decent chance they're going to spend a bunch of money and not even gain anything from it. But you got to win cases for that. And there's been not a lot on the sort of physician side or the sort of vertical hospital physician side there. And I do think there's some question, which is more of a federal question here, of do we need to change the underlying antitrust statutes here to make it sort of easier or sort of lessen the burden of proof, to sort of win in an antitrust lawsuit here. Next, I think there are plenty of areas, again, that would be good to do regardless of just sort of fixing payment policy. Some of these aren't really PE specific. Site neutral payments is probably, more on the hospital side of the coin, but Medicare Part B drug payment, for instance, basically these are physician administered drugs. So ophthalmology is a big space for this, where, in rheumatology, where when the physician is the one administering the drug, Medicare basically pays the doctor more money when they administer a more expensive drug. So part of what we see is that happens, right? That the sort of private equity owned practices in ophthalmology, at least where we have evidence, tend to use more expensive drugs when there are sort of otherwise equal options. And this actually sort of fits the story that we'd seen in the dialysis setting and other somewhat older work here. Again, Aaron sort of touched on all this, so I won't belabor it too much. But there is, sort of all of the anti-competitive regulations that are out there would be important to sort of tamp down on. And sort of more broadly, especially given the point that I think private equity, the sort of net impact of private equity would likely be at least better than it is now if there was more competition at play. Removing barriers to provider competition is important, right? So, getting rid of certificate of need restrictions so that we can have that, to make hospital entry a little bit easier. Not states not shielding. States will often step in with a COPA and basically say, I want to let these two hospitals merge. I don't care, and I'm going to basically, they can cut the federal government out of it and say, I want to make sure these guys merge. That's generally going to be a negative. Right, I think that's important. Right, a lot of what private equity does, sort of more specifically, at least sort of the anecdotal research here, they make very heavy use of non-competes, which again can just stifle competition. Right, if it is harder for a group of doctors to go start their own independent practice, they have to move state lines to do that. Right, that is just going to limit provider competition and sort of, I think, sort of worsen the effects that private equity can have in these contexts. Then the other sort of bucket of solutions, which Aaron talked about, and honestly is more of an expert than I am, at least on the first one here, is, right, one is just, there is some question here of whether it is sort of the corporatization itself that is always going to be a net negative, or at least more often than not going to be a net negative. And therefore, states could take sort of strong efforts to strengthen their corporate practice of medicine restrictions, to work very hard to kind of stop private equity from buying anything in their state, or buying any medical practice in their state, or any hospital, or any nursing home. I also think there are sort of softened versions of this, that once you are doing stronger review of transactions, once you have transparency of the transactions that are happening, it is easier to at least apply sort of a higher bar to some degree. I think it's reasonable to be more aware that there might be some sort of sneaking around in terms of how much they already own of the market when you're dealing with the sort of private equity or on hospital purchasers in this context. People will often point to the corporate practice of medicine often exempts hospitals. That is one of the issues here because, right, private equity is a big consolidator, right? Even in those specialties, maybe it was, 5 to 10% of doctors work for private equity, 50% of doctors work for a hospital. Like that's still the big behemoth here. But again, private equity is growing, and and the sort of Optum model has been growing as well, where about 1% of doctors now work for United Healthcare. And then the last one, which got teased in the sort of Q&A, and the last one is there probably is a limit, right? I think consolidation is a large driver of prices, but it is not the only driver. A lot of these things are probably beyond, right? If you look at the effects of hospital mergers, they don't explain nearly the entire price growth that we've seen. Some of hospitals would argue that that price growth is generating higher quality care and is important to keep their doors open and all of that. It's not quite clear when we look to other countries here. And to David's point, right, it is almost every other country has some form of price regulation. That could be that is the other option here, fundamentally. I think even if you are doing price regulation, making sure we have as much competition is still good. We have evidence from the UK, for instance, where, provider competition, even though there's not really the price channel there, more competition still improves quality. So I don't want to sort of, it's not an either or kind of decision here. But at the end of the day, if the goal is to really reduce prices and really reduce healthcare costs, I should say, which in turn would have very big effects on the employer market, would have very large increases in wages that would result from that. If that is the goal, at some level, folks may want to think about price regulation. And again, that is very dialable, and I think that is important. Where particularly, right, our system in general is sort of an incremental one. You can do that. You can institute price regulation that is sort of very focused on the right tail of prices. You can focus on the highest priced hospitals in the state. And really kind of the idea here is you say, okay, we are going to create sort of like a default contract where if any insurance company wants to, they can agree, they can sort of force the provider to agree to some contract at 200% of Medicare, something that is pretty high price. But the insurer always has sort of that out in the negotiation, and that sort of gives them leverage. They don't have to use that contract, but that would give them leverage to lower prices. You also can tie price regulation to levels of consolidation. There have been proposals to that effect where, price regulation takes effect once a hospital controls more than 30% of the local market, or the sort of some other measure of consolidation reaches some tipping point. Right, that also would be that might be a pretty big incentive to avoid that level of consolidation. On that end, I was hoping to turn it over to Q&A here, and very happy to answer any questions. And again, feel free to reach out to me afterwards.
Wonderful. Thank you so much, Loren, for a wonderful presentation. We have a bunch of great questions that have come in. One set of questions really deals with private equity acquisition and various other areas in the healthcare delivery system, specifically behavioral health and psychiatric practices, and also in the dental setting. Can you talk to those a little bit?
Yeah, so that's a good point. So you're right. You're right. I didn't quite capture the full panoply here of private equity activity. Behavioral health has been, that is actually a pretty recent one where there has been a lot of activity. That is also an interesting one on two sides. One, so part of the attraction has been enforcement and the new mental health parity rules, which basically have increased how much money there is in it. Right, there's no interest in specialties where there's no money, or in facilities and that sort of thing where there's no money. Now with sort of higher payment rates out there, there's been sort of this big drive into behavioral health, trying to sort of get in on the extra payments. In theory, again, right, they could be tailoring more, to improving patient experience. This is one where I do not know of any sort of good evidence on the quality side here because it is so new. There's been papers sort of documenting that it is happening a lot, because you also have, you on the one hand, there is, particularly regulations. There may be some consumer sort of shopping here. But I think you could also see, particularly for older populations, where there really is the sort of, it fits a little bit into the nursing home context, where there probably is a pretty big information asymmetry, and some stickiness in which behavioral health facility folks are ending up at. So I think there is very real reason for concern here. I know there's been some movement in Congress to try to get some answers about what's been going on, just like letters to the companies kind of thing, trying to get some answers on this as well. On the dental side, so it's been going on for a while in the dental context. This is when I first kind of got into the private equity stuff back in 2017 or so. A lot of the sort of PE side people I talked to were kind of talking about dental as that was kind of their big thing. There's tons of money in dental. It's a lot of private pay. There's pretty little public pay. There's Medicaid dental that's happening, but there's a lot of the individuals paying. In some sense, again, right, there's a fair amount of shopping in dental. There's a fair amount of consumer-facing element of that. So I think you can spin a story there. There's obviously it's very hard from the outside to tell who's a good dentist and who isn't. From a sort of federal perspective, you tend to be a little less, there's less public dollars at play here. Right. The nursing home context is basically just all Medicare and Medicaid. So one, there's just a lot of levers. There's a lot fewer levers in the dental context that I think are sort of important to keep in mind. Again, I don't think we have seen anything really on the quality. I assume you're going to see higher utilization, higher sort of use of unnecessary care. The sort of few instances I have heard in the Medicaid context are all about kind of like churning out, just doing a ton of services. In the private pay context, I guess I'm a little bit more open-minded on the effect it might have in dental. But this is, I'm sort of the researcher side of things here, so I don't like to pre-run conclusions before I've kind of seen the evidence here. At least you could spin a story in something like dental where, there's at least people change dentists not infrequently, right? There is some element of shopping here.
Thank you. Another question that's come in is really asking more about PE ownership and how it relates to organization of labor, unionization, and strikes. What kind of patterns do we see in that realm?
That is a good question. There hasn't been a ton of unionization of sort of office-based physician staff as a general rule. You've seen that more recently in the hospital context. I have not, in the hospital context, which I didn't tease on as much, but hospitals are basically all sophisticated businesses. So it's plausible. It's unclear how much different, even your sort of, the question, the last one, the nonprofit Catholic hospitals operate on a pretty poor, they're pretty profit oriented in other ways. So that there may not be as much of a difference in terms of sort of workforce treatment. And the only evidence I really kind of know of in the sort of employment side of things really is just sort of broader on the hospital side when we see hospitals consolidate, when we see sort of more hospital consolidation, we do see lower wages. So the hospitals are basically able to use that power in their negotiation with workers as well. Although in that context, it's really generally what you might think of as the somewhat less mobile staff. So it is the RNs or the other medical staff other than the doctors. Often doctors, at least at the beginning of their careers, are kind of pretty mobile in where they're selecting to go. But we have seen a fair amount of evidence that sort of the more consolidated hospitals are able to pay nurses substantially less money and have worse working conditions. So I would sort of expect a similar thing from private equity. And certainly if you just sort of talk to folks, again, this is a little anecdotal, which I don't love too much, but you see a lot higher use of, you hear a lot about non-competes. You hear a lot about non-disclosure agreements where folks are kind of, their hands are tied when they see something they don't like. They feel they don't want to go forward on, they don't want to come forward on it. I haven't really thought as much about the unionization context here, so I don't know if I really have a great answer.
Great, thanks so much. There's another question here that says variation is a factor in poor outcomes and higher costs. And the question is, can consolidation help in the long run by requiring better use of evidence-based care and best practices for services such as ER turnover, bed turnover, et cetera? Those are tough to execute when independents support your hospital.
That's a great question, right? I think that is, and that's the argument you're going to hear for the most part is one, there are some economies of scale, although I guess I'm pretty skeptical how far the economies of scale go in a hospital context. They're all, it's pretty, you're at a decent sized acute care hospital pretty quickly. In the physician context, it's kind of unclear once you're past like a 20 doctor practice, how much are you really gaining economies of scale going forward? I think the diffusion of knowledge is an important question here, right? And that's sort of the argument in that fertility paper, the fertility chain paper I was talking about, is that they are diffusing sort of the best practices, in the industry. I think there's some question in a pretty globalized economy that we have today, if that's sort of how much of that is kind of an equilibrium outcome, right? Is that something that would have happened anyway, right? There are a million consultancies, there are EHR vendors, there are folks who are trying to sell folks on, what is the right type of care to give when. I think there's some element of how much of that would have happened maybe 5 years later, but it would have happened at some point that I do think is sort of important context in this setting. And again, I think just needs to be weighed, the sort of uncertainty of maybe there are some effects here needs to be weighed across what is pretty high certainty that there are leading to notably higher prices for consumers and in turn lower wages for workers here. And I also think leads you to thinking about non-ownership or non-merging forms of coordination. So in the accountable care organization context, for instance, there are often hospitals and physician groups working together who do not actually, there's no ownership arrangement. They just have they may have some sort of shared savings arrangement or something like that. But I do think you can get some of that clinical coordination without the outright acquisition. And from a antitrust regulator perspective, I think that's sort of where you would prefer things to go, given the sort of laundry list of negatives that we know from particularly horizontal consolidation and growing in the sort of vertical consolidation context as well.
Thank you, Loren. Another question is really asking about whether there are particular aspects of the healthcare delivery system where you think there might be more openness to policies to limit private equity purchases. So things like, we already talked about the dental industry or nursing homes. Are there particular places within the healthcare delivery system where there may be less resistance?
So that's a good question. I think nursing homes I think things with, the sort of where there is sort of a real estate portfolio attached to it. I think and where you're dealing with a pretty heavy life or death scenarios, and where I guess for me, one of the biggest risks of private equity is the risk of bankruptcy and the risk of going under, where I view that as more of a concern in the nursing home context, not more so than anything else, just because finding a new nursing home is a real burden to place on patients, more so than in hospice as well. Some of these than finding a new physician. Again, with the physician one, if you go bankrupt, you probably can still see that human being. That your doctor is going to just work somewhere else. Often bankruptcy in the healthcare context is not actually what people think of in their heads as bankruptcy. It is sort of we're going to wipe out the bondholders or cut the bondholders here, and they often stay in business. So most healthcare, even the nursing home context, most healthcare bankruptcies, the nursing home continues to operate. Really what it is sort of a debt negotiation with the debt holders. There is some evidence that there are negative consequences. There's higher staff turnover. A lot of the private pay patients leave the nursing home upon bankruptcy. But in my eyes, that's sort of, if you're thinking about where to be more concerned versus others, I think the contexts where going out of business is more important, or sort of more, I should say, that can be worse, are kind of the areas to be more concerned. So nursing homes, hospitals, I think behavioral health facilities fit into that context. I would say in my eyes, I think those are kind of the where I see some of the bigger quality risks, at least. I don't want to rule out quality impacts on the physician side as well. But I just in terms of kind of focus, I think that's right. And then, actual action sort of very focused on private equity is difficult. And I don't know, there's been some state movement on this. Oregon, for instance, has been discussing certain bills sort of targeted at private equity. I think at least holding a higher standard towards some of these acquisitions can be useful, particularly when we now have a fair amount of evidence that there are price increases, or in the emergency medicine context, that there was sort of higher surprise billing when they were buying practices, right? I think that is important to keep in mind as the regulator side of the coin.
Thanks. One more question, and then I think we'll be out of time. But can you talk a little bit more about the price regulation option that you talked about? Specifically, are those price regulation ideas coming from the federal, the state level, and what are the mechanisms? Is it participation in Medicare? Is it something else?
That's a great question. Like most things, it's sort of easiest at the federal level because you have the most levers and you have Medicare participation to tie everything to. The state level, you've still got Medicaid participation to tie things to. I mean, if you have state licensure of providers to tie things to at the state level. So it's not like there are levers at the state level. My experience in working with states is that there often isn't really a regulatory apparatus in place on the provider side at the state level. Right? They generally have some sort of Department of Insurance to regulate insurers, but often don't have a lot on the sort of, other than licensure, don't have a lot on the provider side of the coin. So it can be difficult. I think the sort of lowest touch version of this is the sort of public option version that we've seen in Nevada and in Colorado and Washington, where, right, that is very narrowly focused on the non-group market, right? That is a small segment of everything. But again, that is the sort of, I guess, if you actually wanted to reduce prices, the core way that is doing it is by reducing provider prices, right? The premium targets that some of those public options have set up, usually the lever on the back end is that effectively you can sort of single-handedly force the hospitals to reduce their prices, at least in Colorado, if the premium targets are not going to be met. That is effectively a sort of backdoor form of price regulation. Which can kind of achieve these aims, whether you're running it through private payers like states have done, or running it as an actual sort of true public plan that is sort of operating, a Medicare-like or Medicaid-like plan that's operating it. Again, there's no reason that can't be applied to the employer market also. That is a very large step, but it could be applied to the employer market. Again, just because it can be done at the state level, I do think there are reasons that it is more difficult. One, just politically, obviously, everything here is difficult, but it is, right? People are very mobile between states in the US, and doctors are very mobile between states in the US. So there is some element to, if you were really strict and like it was, in Nevada, doctors can't get paid more than Medicare, it is perfectly plausible that you might see some exodus to other states and have more difficulty attracting doctors to work in Nevada. So I do think that is, whereas if you're doing it federally, it's a lot more to move to another country. And honestly, they price regulate harder than we would. So that's not really going to accomplish you much. Right, I think that is where this often happens. And then the sort of there are different versions of price regulation out there. A lot of them are just sort of like straight price setting, say, okay, we're going to pay, it's basically Medicare, right? It's like, we're going to pay 150% of Medicare for this, pay 170% of Medicare for this. I think that's very difficult to accomplish, particularly at the state level, but I think sort of anywhere. Whereas the sort of option I was kind of teasing, my colleague Matthew Fiedler at Brookings has written a lot more on this if you're interested in sort of public options and price regulation here. But the general idea here is that you can think of it as, okay, you're basically saying the doctor or the hospital really is mostly what you're focused on here. They can't charge more than, let's just say, 200% of Medicare. They can't charge more than twice the Medicare price. And if an insurer wants to send patients there, they can't just turn away patients, because typically the hospital's leverage isn't really, it's actually just that I'm not going to treat the out-of-network patient. Like if I'm not going to get paid what I want to get paid, I just won't treat you. So it'd have to be accompanied by some access requirement. So it's sort of, you can't charge more than this, and you have to offer meaningful access to patients at that price. That effectively gives leverage to the insurance company to walk away, right? That is sort of their best alternative. They can say, if you aren't being reasonable, hospital, I will just take this. In practice, I suspect you would almost never see that get taken, because they can almost always think of a contract that is better for both of them than like a simple 200% of Medicare across the board. But maybe they can't. But like it leaves them, it's less micromanaging, to make up a word. But I think that's sort of the attraction, where it's very difficult to go through as regulators and sort of pick and choose every service. This sort of lets the private actors still negotiate, but under sort of providing more leverage for cost control there. And again, they're sort of, it's like the non-group market is the smallest version of this, and then it's sort of applying that to the whole employer market. Is kind of, that's where the money is. That's where 160+ million people are getting their insurance.